Welcome to Menopause Talks. My name is Donna Klassen, and I am the co-founder of Let's Talk Menopause, a national nonprofit organization changing the conversation around menopause so women get the information they need and the healthcare they deserve in midlife and beyond. Our menopause talks are central to our education efforts, and our past 20 menopause talks are on our website. All menopause talks are intended for informational purposes only, not as a substitute for professional medical advice, diagnosis, or treatment. Before we get started, we have a few housekeeping items. We've disabled the chat and will only be using it to provide you with information, so check there throughout the talk. Please ask your questions in the Q&A. We have designated time at the end of the presentation for questions and answers. There will also be a brief survey at the end so that we can complete that when we ask you to complete it so that we can continue to improve our offerings. Our topic today is hot flashes and night sweats, causes, ripple effects, and treatments with Dr. Jewel Kling and Dr. Denise Millstine. Dr. Jewel Kling is a professor of medicine, chair of the Division of Women's Health Internal Medicine, Assistant Director of Women's Health Center of the Women's Health Center, and Dean of the Mayo Clinic Alex School of Medicine in Scottsdale, Arizona. Dr. Kling has dedicated her career to studying and improving care related to menopause, female sexual health, and LGBTQ health. Dr. Kling is recognized as an institutional and national expert and leader in menopause. She speaks at national meetings on topics related to menopause and hormone therapy and has published extensively in the field. She's a Menopause Society certified practitioner, a fellow and board member of the International Society for the Study of Women's Sexual Health, and Gender Health Collaborative. Welcome, Dr. Jewel Kling. Dr. Denise Millstine is a board certified physician in internal medicine at the Mayo Clinic in Scottsdale, Arizona. Dr. Millstine's interests include women's health, integrative medicine, menopause, narrative medicine, and the use of books and reading to improve health understanding, and empathy. She directs a women's health blog for the Mayo Clinic Press. She is also the creator and host of the Mayo Clinic's Read, Talk, Grow podcast, where she talks about books and health with authors and experts. Dr. Millstine provides consultations in integrative medicine through the Women's Health Center at the Mayo Clinic. Now I will turn it over to Dr. Jewel Kling and Dr. Denise Millstine for a discussion on hot flashes and night sweats and what you can do about them. Thank you both.
Thank you, Donna.
Yeah, thank you so much, Donna, and thanks for the super important work that you do. You know, Dr. Millstine and myself love talking about menopause and probably do that more than 8 hours per day and are so excited to do that for an hour with y'all tonight, but recognize that there's not a lot of forums for women to hear about this information. So you creating that platform is just so important. So for everybody that's joining, welcome. Dr. Millstine and myself are going to go through some questions and just have a conversation about hot flashes, night sweats, what they are, how we treat them. And then at the end, we'd love to open it up for questions. For your knowledge, we're going to go ahead and use our first names because we're colleagues and friends and thought that may be a little bit more conversational. So it feels like you're just sitting in a room, maybe with a cup of coffee, or it's 8 o'clock at night. I hope you're not drinking coffee, maybe a nice tea or something. And you can hear a little bit more about menopause, including maybe the good, the bad, and the ugly, but all the treatments too to help you out. So without further ado, why don't we start, Denise, with just the basics. What are hot flashes? What are night sweats?
I love how you say this is the basics, as if it's clearly been elucidated and we've hammered out the exact mechanism of why women have hot flashes during this transition. The truth is we don't understand this fully, but what we know is that with estrogen withdrawal, so that means you've had estrogen circulating in your system, typically coming from your ovaries, that drops at some point. Maybe that drops because you had a surgery to remove your ovaries, ovaries, or you received chemotherapy and it shut down your ovaries, or just naturally with time, your ovaries kind of slowed down and stopped making all that estrogen. So with that drop, that withdrawal in estrogen, there's an impact in the parts of our brain that affect what we call thermoregulation, your ability to manage temperature. And what starts to happen is that is off. So now instead of having sweating and getting warm when you're outside on an Arizona day, instead you get this vasodilation of your blood vessels in the distal parts of your body and the end parts of your body, and you start to sweat and feel hot, but it's not in response to necessarily what's going on with the ambient temperature or even your situation. So it can be quite disturbing because you're in the middle of a meeting at work and suddenly you start having these hot flashes. What's really interesting about the cause of hot flashes and what's so exciting about the work that's happening in women's health right now is that there is recently this area of the brain that I think you're going to talk about a little later that has been identified as being important as a driver for hot flashes. So we'll get into that a little bit more when we talk about treatment options. But I think this question of what causes women to have the symptoms that they have is critically important and something that for a long time science really hasn't paid attention to.
Well said. And while I recognize for many it's 8 o'clock, and so we don't want to get too sciencey, I'll just mention what you're talking about. There's this set of neurons in our brain called the candy neurons, not candy like CANDY, but the KNDY, but still like a kind of cute name, right? That secretes neurokinin B. And later we'll talk about a medication that blocks that. So it's super cool because it goes to the root of where those hot flashes may be generated when your estrogen drops, as you said so beautifully. Denise, I started with hot flashes and night sweats. I know we call them vasomotor symptoms as well. Can people have hot flashes without night sweats? Like, why do we lump them together? Anything we need to know about those individually?
Yeah, I just think that we lump vasomotor symptoms together because it's the same process. And when it happens at night, we call them night sweats. But you
Mhm.
can most certainly have night sweats without hot flashes without night sweats. And then many, many women have both. One of the things I think it's important to think about when women are considering how do I manage menopause, what sort of treatments am I eligible for, or should I consider, is how disruptive it is, right? So if you're having hot flashes during the day, but you're riding through it and it's not upsetting your rhythm, and then not having hot flashes, not having night sweats, maybe you don't need treatment. But if you're having night sweats at night and now you can't get a good restorative night of sleep, that's going to have lots and lots of impacts on your mood and your ability to concentrate and all of that. So really important to look at what symptoms you're having, and you can have both or either, and whether or not you should be considering treatment because if it's bothering you or not.
Yeah. I wonder if you've seen this in your clinical practice, Denise, but I think, and maybe not even clinical practice, just in our communities, that maybe we don't even recognize how much it's impacting our symptoms. So I'm glad so many people are joining us to have that chance to really think through it, because I reckon that many of us are really tough and resilient, and maybe have heard this idea that you're just going to tough it out right
Yeah.
through menopause. But I'm so glad that you brought up how it impacts all of those symptoms. Sleep is so critically important, and menopause happens around our early 50s when many of us are like hitting the stride in our careers or hitting the stride in our life, feeling really like competent and excited about living our lives. And if we aren't getting sleep, if we're distressed by vasomotor symptoms, if we're having mood changes, that can absolutely make an impact, right? And so maybe stepping back and taking the chance to look at that and how it can impact things. Um, I know there wasn't really a question in there for you, but I thought I would just say one other thing, and would love your thoughts on this too. But we recently did a study at Mayo where we looked at the associations of menopause symptoms and adverse work outcomes. And I think probably not a surprise to any woman that's working and having menopause symptoms, we found a strong connection between those two. In fact, on average, women reported missing about 3 days per year because of their menopause symptoms. And when we extrapolated that to economic data, looking at the whole US, that would translate to about a $1.8 billion loss just based on missing work because of menopause symptoms. So those are some of those impacts, that I think you're alluding to.
Well, and I think you're right that money talks. And so while women's health is important to us as women's health physicians, sometimes in order to get the general population or some of the payers to consider it, we have to look at it in economic terms. And like you said, it's very real. What are other impacts of hot flashes on social life and relationships?
Yeah, I think you touched on a lot of the really important ones. And maybe making a couple of connections here too, because one of the common things I hear from patients, and I know we're talking about the hot flashes and night sweats, but one of the really common symptoms of menopause is weight gain. And recognizing that the secondary impacts of night sweats on your sleep, how that then influences your weight is really important. So if we can address those, it's going to help women achieve their goals or at least be less distressed by those things that may be occurring during menopause. I wonder if the other thing you're asking about is kind of the bigger picture consequences of menopause and hot flashes and night sweats. We know at midlife, this is the time when our risk for things like cardiovascular disease start to go up. And interestingly, we have seen in studies that women that have more hot flashes, that's associated with increased cardiovascular disease risk in the future. And so there may be a linkage there. We don't know definitively if treating those hot flashes and night sweats are going to prevent that cardiovascular disease, but certainly it, raises it to our awareness that if we're having those, we need to be seeking treatment and then also practicing those heart healthy activities, right? So that we're not suffering those consequences post menopause.
Jewel, what about brain health? Can you comment on that?
Yeah, and that's another super common symptom. I wonder, the folks that are listening, they're like, "Oh yes, please talk about brain health." Because ever since I started going through perimenopause or menopause, I just have this cognitive fog, which is the word that a lot of women tell me. You can't hold on to words, or you'll walk into a room and can't remember what you were, going into that room for. And we do see studies that supports that there's some changes in your cognition around menopause. It's in that it's called the executive memory, not like you're an executive at a workplace, but it's where you hold all those, important memories and names and things. And so it is impacted during menopause. But the good news is that we see that resolve after the menopause transition for most women, and it's not a sign of impending dementia. But maybe another reason that if you're experiencing those symptoms to really seek treatment, because many women do notice that once their hot flashes and night sweats are treated, that those symptoms are improved.
We actually have a question already in the Q&A
Oh,
where
great.
Christelle has said, I understand vasomotor symptoms are linked to an increased risk for cardiovascular disease, and women should seek or at least consider treatment to alleviate them as opposed to toughing it out and putting up with it. I love how you phrase that, Christelle, because that is exactly what Jewel is talking about, that these
Hmm.
impacts we don't really understand if treating the hot flashes is going to lead to better heart health, but this is the science that needs to be teased out.
Hmm.
Um, I think the next area we were going to go to is how long hot flashes last. And I think this is really something that has just fairly recently come to light. I've heard a lot of people be told, oh, it'll just be 3 months or, oh, it'll just be 5 years. I think that gets confusing because people are thinking about timing of treatment and that type of thing. But what we know from some really great data, particularly the SWAN study, which is a study of women across the nation, that the median amount of time that women have hot flashes is 7.4 years. That's years, ladies. So to be clear, a lot of these hot flashes will start, like Dr. Kling said, in that perimenopausal period, not necessarily only starting in menopause. Jewel, do you want to tell everybody what perimenopause is?
Yeah, I'm so glad you asked because I was thinking it would be good for women to know that, and for anybody to know that, including partners, loved ones of folks that are going through menopause. But Yeah, so menopause is defined clinically as 12 months past the last menstrual cycle, and on average, it's about age 52 in the US. Perimenopause is any change that starts before that time. So oftentimes it'll be changes to the menstrual cycle, it could be sleep issues, it could be hot flashes and night sweats, and that can occur years before the last menstrual cycle, so 3 to 5 years. So if we're kind of mapping that out, usually around the mid 40s, women may start experiencing those symptoms.
And when
Yeah, go ahead.
Well, I was going to say, and when women get earlier symptoms, they tend to have symptoms that last longer. And about 8% of women are going to have hot flashes for, wait for it, 20 years or more.
Oh,
20 years. It is so long. So this can have an impact for a really long time, which is why it's so important to keep talking about it.
well, and I find when I share that with women that are experiencing those symptoms, it really does need to go hand in hand with a conversation about treatment options, as well as exploring those, risks and benefits of all those treatment options, um, because it does. I mean, that really is distressing to hear that it's going to go on for so long, especially if it's causing so many impacts. So I'm glad that we're going to transition to that. But before we do, just wanted to take the opportunity to talk a little bit more about the timing and duration, because there might be folks that are on this Zoom that are thinking, you know what, I don't. Are they talking about me? Because we do see some differences based on different women, different races and ethnicities. So I thought I'd just briefly talk about that, and we can kind of transition to some other things, unless there were other things you wanted to talk about with timing and duration, Denise.
No, I think this is so important. Maybe we can talk a little about risk factors too, but let's talk about how different women have a different experience.
Yeah. So we do see, and mostly from that SWAN study that you were talking about, and maybe that's an important caveat here, is that the research that surrounds menopause has been limited because it hasn't really included a robust amount of diverse women. And so a lot of the information that we're sharing is really based on cisgender white women, and we're extrapolating that beyond that. We do have some studies like the SWAN studies that have looked at women from different races and ethnicities and backgrounds. And what that has found us or taught us is that Black women tend to go into menopause earlier, and Latinas and non-Latina Black women experience more frequent vasomotor symptoms or hot flashes and night sweats, as well as more sleep disturbance and depression. So I think that's really powerful for us to know, to both to validate if we are part of one of those groups, but also, as clinicians that we're offering those treatments too.
Yeah, and in general, as a general statement, I think women who are smoking, women
Mhm.
who are less physically active, and then women also with obesity tend to have more severe vasomotor symptoms as well. So that's something to think about because it's a good reason to quit smoking. It's a good reason to put on your sneakers and hit the bricks.
I love that. And that pulls back to what we were talking about earlier about this being a period of time where our risk of cardiovascular disease starts to go up. So if you're getting benefits to your symptoms and feeling better, and then also knowing that it's going to reduce your risk of things like cardiovascular disease and even breast cancer, hey, that can certainly help you be more successful in implementing those things in your life. Well, what do you think? Should we start talking about treatment options?
Yeah, I think we should. And I know this wasn't part of the plan, but I already see a question in the
Let's do it.
Q&A. So, anonymous attendee says, I'm on the estrogen patch and my doctor said she will not prescribe it after age 65. How long do I need to be on the patch? So let's talk some general information and let's make sure we answer that question because I think it's a tricky one for a lot of women. So what
Mhm.
anonymous attendee is referring to is what we currently call hormone therapy or menopausal hormone therapy. And what that typically involves is estrogen, typically estradiol, at a much lower dose than you would get if you were to take, say, an estrogen based oral contraceptive or, quote, the pill for contraception when you're premenopausal, when you're taking that to prevent pregnancy or to regulate your periods at that point. So it's a much, much lower dose of estrogen, and that is going to be your symptom driver, meaning it's going to reduce your symptoms. And we're going to pair that with progesterone, with a form of progesterone to protect the uterus. Because when we give women estrogen and there's no progesterone, we put them at a higher risk for having changes in the uterus that eventually can become dangerous and worrisome. So in women who have a uterus, meaning they have not had a hysterectomy, we are typically using a very low dose of estradiol paired with an oral progesterone. There's a question in here about whether a woman who doesn't have a uterus needs to take progesterone with her estradiol, and she does not necessarily need to take that. There will be some isolated instances where she might still choose to take the progesterone, but as a general statement, that woman who's had hysterectomy, who has vasomotor symptoms related to menopause, is going to be on estradiol. And our practice typically is to use that in a transdermal preparation. So that means as a patch, or it could be another product, but typically through the skin, not through oral application. There are other ways to provide the estradiol, but I would say the vast majority of time, what we think is safest for most women is to do that transdermal application of the estradiol paired with the oral progesterone. Jewel, there's actually a question already in the chat, in the Q&A, about early menopause. Do you want to, I know
Oh,
this wasn't on the list, but it's so important and so often
yeah.
misunderstood. Do you want to talk about what hormone therapy looks like in a woman who goes through an early menopause?
Yeah, I'm so glad somebody asked that, and maybe I can use that to then dovetail to talk about how we may approach perimenopause a little bit differently, so some different scenarios. But before I do, just wanted to echo what you were saying about the non-oral estrogens. And for those that are listening, we keep using the term estradiol, which just that's the type of estrogen that we use, and it's considered bioidentical. It means it's the same hormone that our body makes. A lot of people use that term bioidentical to suggest something might be safer, like if you compound it. But bioidentical, again, just means that it looks like the same thing that our body uses. And the really cool thing is that we have plenty of FDA-approved bioidentical products that are safe and effective for treating, the symptoms of menopause. So with that, let's talk about premature menopause. Premature menopause is defined as going through menopause before age 40. Early menopause would be before age 45. For those of you that are listening and may think, oh gosh, I'm 39 and I haven't had a menstrual cycle in a year's time. In that situation, we would encourage you to talk to your clinician about getting evaluated why you may not have a menstrual cycle, because there's sometimes some underlying medical conditions that can contribute to it. But a majority of the time, we don't find an underlying medical condition. But then it really behooves us to make sure that you're on, in this situation, we would call it hormone replacement therapy as opposed to menopausal hormone therapy. There's a subtle difference there. The hormone replacement therapy is really to give you back the estrogen that your ovaries would have been making until the average age of menopause, because we've seen in multiple studies now that women that go through menopause prematurely and are not on hormone replacement therapy have higher risks of many long-term health consequences: osteoporosis, cardiovascular disease, dementia, Parkinsonism, sexual dysfunction, lower quality of life. And so the good news there is that if you're on hormone replacement therapy, at least until the average age of menopause, that it mitigates those risk factors. And the same, like what Denise was saying, if you have your uterus is still intact, you'll need both an estrogen and a progestogen. But if maybe you're somebody that had premature menopause because you had a surgery, for example, women that are gene carriers that have the BRCA mutations, which are associated with a higher risk of breast cancer, they'll sometimes have their ovaries and their uterus removed, plus or minus their uterus removed, and need hormone replacement therapy. In that case, you would just need an estrogen if your uterus was removed. Similarly, if you go through menopause below 45, you may also consider doing hormone replacement therapy up until that average age of menopause to get those long-term health consequence benefits.
So let's talk about what that question was in the Q&A about whether that woman needs to stop her estrogen therapy, or excuse me, her hormone therapy at age 65. I think this goes to the issue with timing. And I like that we just paired it with the early menopause, premature menopause, because it really depends when you start the hormones and why, and what the rest of your medical history looks like in terms of how long it is safe for you to continue on hormone therapy. So, in the example that Jewel just mentioned, if you started hormone therapy at 40, you are not going to stop it after 5 years unless there's a clear reason that you have to, because we haven't talked about this yet. There are risks with taking hormone therapy, lots of benefits, but also lots of risks, which women need to know before they start them. But in that person who's saying she's 65 and she's being told that she has to stop her hormone therapy at 65, I think it is always a good idea to be seeing your healthcare professional, your team every year to ask, like, should I continue taking this? What's my risk
Mhm,
to my benefit? But
mhm,
remember, we just said a number of women are having symptoms 20 plus years.
mhm,
So it is not one rule for everyone. And if you're
mhm.
seeing somebody who is telling you that I have a hard cutoff, maybe consider seeing a menopause expert, a certified menopause expert who can at least help you walk through the choices that you're making as you're looking at what are the benefits I'm getting compared to what are the risks that I'm taking. Jewel, do you want to talk about the risks of using hormone therapy?
Yeah, and beautifully said. I'll just emphasize that what you just said is also guideline based. So if you're getting resistance or whatnot, and having a conversation with your clinician, this is supported by the most recent position statement from the Menopause Society that says we shouldn't use an arbitrary age cutoff. That it's really individualized, looking at those risks and benefits. And maybe I'll take the opportunity just to step back a little bit and talk about, women going through menopause at the average age at 52, experiencing vasomotor symptoms. What are the guidelines that dictate that kind of risk benefit thought that we're talking about? And a lot of this is rooted in the history of the research in menopause hormone therapy. Some of you may have heard of the Women's Health Initiative, big study back in the 1990s that was put together to really evaluate the safety of hormone therapy. Before that time, docs were putting women on hormone therapy to prevent cardiovascular disease because there were observational studies that showed it reduced heart disease risk. Well, this study, unfortunately, was closed early after 5 years because they found higher rates of heart attack and stroke, which just didn't track with what we were seeing before that. And it turns out the reason that we saw those increased risks is because the average age of women enrolled in that study was 63 years of age. So they were more than 10 years from menopause. And when we looked at the women that were 50 to 59, so less than age 60, in fact, starting hormone therapy early in menopause was not associated with the increased risk of cardiovascular disease or substantially an increased risk of stroke risk. And so certainly these are things you'll hear, right? Cardiovascular disease risk, stroke risk. If you've experienced those, heart disease or stroke, that would be considered a contraindication to hormone therapy. But if you've not experienced those and you're less than age 60 or within 10 years from your last menstrual cycle, typically the benefits of hormone therapy for the treatment of hot flashes and night sweats and potentially for the prevention of osteoporosis typically outweigh the risks. The other two, just to round it out with the contraindications to hormone therapy, would be if you have had breast cancer or a hormone positive gynecologic cancer, and if you have active liver disease or a significant history of blood clot.
Yeah, thank you for that. We have another question, which I think we definitely should address right now as
Let's do it.
well. One of the attendees is asking about progesterone in a non-oral formulation. So I'll take this one if it's
Okay,
okay.
yeah, do it.
I would say the standard is to use that transdermal or through the skin estrogen along with an oral progesterone. And this is going to be the safest way to protect your uterus. While it is not FDA approved to do so, many of us instead, for people who do have trouble taking an oral progesterone, are actually recommending an implanted progesterone secreting IUD. So, you have different types of IUDs, some that have drug that's a very low dose, just locally secreted inside the uterus, and others that are working through another mechanism. But in a woman who has a hard time taking the oral progesterone, we will not infrequently use the transdermal through the skin estrogen and pair that with progesterone inside the uterus through an IUD, which can be present for several years before it needs to be changed. So it's pretty slick, and I can't wait for this to reach guideline care as well. It is not safe to use your progesterone transdermally. So if somebody's recommending that you put on a progesterone cream to go with your estrogen patch, this is not good medicine. Please don't do that. If you are already doing that, then you should see your provider to make sure that your uterus is okay and you haven't developed what we call uterine hyperplasia, endometrial hyperplasia, buildup of those cells, which have the potential to become abnormal or even cancerous. So, general statement is going to be estrogen through the skin, progesterone's coming in orally, but then some women will choose to use it as a direct endometrial application through an IUD.
Yeah, well said. And I'll say the only exception to that is there's two patches that have a combination of an estradiol with a synthetic progestin. So if somebody's listening and they're like, oh, wait, hold on, my progestin's coming through a patch, that's different and that's okay to continue. That will give you that endometrial protection. And this may give us a great opportunity to talk about perimenopause, because I'm also a fan of the progestin-containing IUDs, and I think the situations where it can be extremely beneficial are for those women that are perimenopausal, so haven't gone a whole year without missing their menstrual cycle and are starting to notice really heavy or abnormal bleeding. And the IUD does have an indication for abnormal uterine bleeding. It also does provide contraception. And that's probably another thing we should call out here, Denise, as well. I think we've probably all had those patients in our practice where, you're entering your late 40s and you're like, no way I can get pregnant again. And then it happens, right? And you can technically get pregnant up until 12 months after your last menstrual cycle. So making sure if that doesn't fit for your life or your health, that you're, using something, and an IUD can be a good option in that case. So for perimenopausal women, an IUD, and then you can use that patch of estrogen to treat the hot flashes and night sweats.
Let me just jump in
Yeah.
on that because I think this is really important, especially for women who've had regular periods. You know that you're able to get pregnant in the middle of your cycle when you're ovulating, but when you become perimenopausal and now your cycle could be shorter, it could be longer, it could be shorter and longer, varying. You just don't know when you're ovulating. So if you have been, depending on the knowledge that you're only going to get pregnant these couple of days out of the month and they've been predictable, welcome to perimenopause. It's no longer predicted. Should we move to talking about non-hormonal management of menopause?
Yes, we
Oh,
should.
you were going to talk about perimenopause. No.
Yes, I did want to just round out the conversation about perimenopause, and maybe take the time to dispel a couple of myths and give a couple of options. I think a lot of people I've heard women say this to me, like, oh, I have to wait until I'm menopausal to get treatment. Like I have to wait until I'm 12 months past my last menstrual cycle to use menopausal hormone therapy. I'm not sure where that came from, but that's not the truth. If you're having perimenopausal or menopausal symptoms like hot flashes and night sweats, then you can start treatment. And for perimenopausal women, you do need to keep in mind that contraception. So if you can get pregnant, an IUD is a good option with an estrogen patch, or some women can continue or start a low dose birth control. I wonder if you've used that in your practice, Denise, and kind of how you use birth control in this situation.
Yeah, no, absolutely. When I'm looking at hormones in women in that perimenopausal phase, I more often am looking at those low dose birth control pills because sometimes I think the menopausal hormone therapy doses just aren't enough.
Mhm. Yeah,
Uh,
especially if there's bleeding, right? That's another great benefit of a birth control pill or hormonal contraceptive. Even if you're not using it for contraception, if you're perimenopausal and having unpredictable bleeding, and maybe you're like, ooh, intrauterine device, I don't want to put something in my uterus, a birth control pill can help regulate the bleeding as well as the hot flashes and night sweats. And we've used the term low dose birth control. So sometimes I think people think that a menopausal hormone therapy formulation is a higher strength than a low-dose birth control. I know you mentioned that at the beginning, but just to reiterate that here, that the low-dose birth control compared to hormone therapy, even the highest dose is about 4 times lower than the lowest birth control pill. And so it's still enough hormone to treat all your symptoms as well as provide contraception. And, women could continue that up until age 55. At that point, about 95% of women will have gone through menopause. So that can be a really nice way to transition through menopause if it's a tool that you've used and it's safe, like you don't have a history of a blood clot or other risk factors.
Okay, are you ready to jump into the other medications? What
Yes.
about fezolinetant? This is the new kid on the block, and this goes to those that new pathway for the hot flashes that's been identified. Can you talk about it?
Yeah, I would love to talk about it. And for any of you that are attending today that watched the Super Bowl, you may have even seen a Super Bowl ad for this medication. The brand name is Veoza, and it was approved last May. It's our first FDA-approved medication that really targets where hot flashes and night sweats generate. It's the second non-hormonal FDA-approved medication. I think we'll talk about paroxetine a little bit later, but fezolinetant was developed exclusively for this purpose, and can be beneficial at reducing hot flashes and night sweats for women who can't take hormone therapy or choose not to use hormone therapy.
One of its problems is the cost, however. It
Mm.
is really exorbitantly expensive. And like you just mentioned, we have some other non-hormonal uh, pharmaceutical approaches that are actually quite effective. Do you want to
Mhm.
give a list of those?
Yeah, and for those of you that are trying to vigorously take notes, I'll refer you, it should be posted as part of this too, that there's a non-hormone position statement that the Menopause Society updated last year that reviewed all of the kind of prescription medications, and it includes fezolinetant. The other kind of classes of medications that we use are the antidepressants, so the selective serotonin reuptake inhibitors or SSRIs, and the serotonin norepinephrine medications, the SNRIs. So that's like paroxetine or escitalopram or Effexor. Paroxetine is the only one that's FDA approved, but all those other ones have good data and studies to show that they reduce hot flashes and night sweats. It's just that those companies haven't taken it to the FDA to get approval for that. So it doesn't mean that it's necessarily less effective at treating your symptoms. I just like to make a point here because I think for a long period of time, for many women, maybe still, how our symptoms are addressed in clinic can feel like it's being labeled as or dismissed, right? It's all in your head. It must be anxiety. And so I want to clarify that these medications are not meant to treat something as though it's a kind of a made up symptom, if you know what I'm saying, but really they have been demonstrated to reduce hot flashes and night sweats. I
Well,
think it's
can
important
I
to,
comment on that?
yeah.
I think it's interesting because we say, well, that would be like insulting somebody to say it's all in your brain, but it is in your brain because your brain is where
No,
these
no,
centers are
you're
happening. No,
right.
I know. I'm
But
just,
I'm not talking about it that
oh, I
it's
know.
all in your brain. It's that this idea that if a woman's suffering from symptoms, it must not be a significant or a substantial thing, right? Like it's a social stigma. The other part is that antidepressants carry a social stigma just within themselves. And so that sometimes becomes a barrier, right? If somebody's like, I don't want to take a medication, I definitely don't want to take an antidepressant, that can be challenging, which is great that we have other medications. But I just want to make that point that like when I'm bringing it up in a visit with a patient, it's not because I don't believe her symptoms or think that those are valid in treating. It's in fact because, to your point, those neurochemicals, the serotonin, the norepinephrine, help reduce the vasomotor symptoms in the brain where those symptoms are generating. So I'll get off my high horse here and talk about some of the other non-hormone options too. There are a few other medications. Oxybutynin or ditropan is a bladder medication that has been shown to be effective at reducing hot flashes and night sweats. And then the other one is gabapentin. You may have heard that medication used for neuropathy or nerve pain, but that can be really helpful, especially for those nighttime symptoms, because it can cause drowsiness as well.
I always like to offer a little caution with the oxybutynin, though, because
Mm,
just like when we're talking about hormone therapy, there's a cost to these medications and a risk to the medications. And we are learning that women who are using these medications for bladder health, the oxybutynin particularly, have increased risk of cognitive decline or memory impacts. So
mhm.
I would proceed pretty cautiously with that one myself.
Mm-hmm. It's certainly something that needs to be discussed, and through that kind of shared decision making model, making sure that patients recognize that. Um, I, I have had some great success with it. When you look at the percentage of vasomotor symptom reduction with the different medications, oxybutynin can be really beneficial. But that's the challenging part sometimes about medicine, right? Is weighing those risks and the benefits. And that's probably why many women turn to us and say, hey, I don't want a medication. And this is where oftentimes I'll be like, I'd love for you to go talk to my colleague, Dr. Millstine, who is trained in integrative medicine. And I don't know if we even discussed that at the beginning, Denise, but I'd love for you to share with folks here what integrative medicine is. And then if you can talk about some of those non prescription options that can help with hot flashes and night sweats.
Yeah, you don't have to ask me twice, Jewel. I love talking about integrative medicine, which is basically the overlap of natural healing practices along with conventional medicine to optimize health and healing. So, in integrative medicine, we swing from this idea of disease management over to how do I make this person in front of me be as healthy as they possibly can be, regardless of their burden of disease, which is part of why I'd love to talk to women about menopause because menopause is not a disease. It
Mm-hmm.
is has a diagnostic code by which we can order different testing or medicines or things like that, but it is not a disease. If you live long enough as a woman, you will go
Mm-hmm.
through menopause. Absolutely. So I love applying integrative medicine strategies. So where should we start? I mean, I think the one that has the highest evidence for effectiveness is something that is effective for many other things as well, and that's cognitive behavioral therapy. So we often call cognitive behavioral therapy CBT. It is a specific type of psychotherapy which has boundaries around it, meaning it is for a certain amount of time for a certain intended outcome. So we use CBT very often for sleep. You can certainly use it for mood, but we know that it's also effective for hot flashes. What's really cool about the data for CBT is you can do this with an individual. You can see a therapist who's trained and do one on one sessions, but you don't have to. You could also do CBT through a group setting. You could do it even virtually. And we're seeing more and more platforms where CBT can be applied from the comfort of your own home, which is nice because you might not live in an area where it's easy to find a therapist. So I definitely recommend CBT for vasomotor symptoms for women who aren't candidates for estrogen therapy, who don't want to take another medication, and particularly if you have some of those sleep effects that can come in middle age, it is really a great way to proceed.
Excellent. Well, I wonder if you have something else you were going to transition to, but I know a lot of patients ask me about over-the-counter supplements and other kind of natural products. So maybe you can talk about that a little bit.
Yeah, I think this is really a tricky conversation to have because you have to ask yourself, are you using the supplement specifically for the vasomotor symptoms? And if that is the case, then it's likely that there are not very many products on the market that are actually going to help you. That being said, I use a ton of magnesium, for example. So women tend to be depleted in magnesium. If you take medications for your stomach health, or you take a blood pressure medication that's a diuretic or what's called a water pill, if you drink alcohol regularly, if you eat a typical American diet, you are probably depleted in magnesium. And what happens when you're depleted in magnesium is you can get hot
Mm,
flashes and muscle cramps and anxiety and sleep disturbance. So I do often think about, is this woman in front of me depleted in magnesium, and would she maybe benefit overall from a magnesium supplement? I think the supplements that we see marketed to women most aggressively are the isoflavones or the soy-based supplements. And I'll tell you, these are so confusing. I study this area and I find it so confusing. It's because they're
Mm.
all over the map and they're not standardized. So they probably should not be relied upon for management of your vasomotor symptoms. Now, if you are eligible to try them, and that means you don't have any of those contraindications that we heard Dr. Kling talk about for hormone therapy. So you don't have a history of breast cancer, you haven't had a blood clot, and you want to try a soy supplement, you can do it carefully from a product that you know you can trust, and you need to take it for 3 months before you decide whether it works or not. But I don't use a lot of them because I
Mm.
have so many other more predictable strategies that I can use. So I know you walk into the health food store and you see aisles or at least shelves of supplements that are going to fix your menopause. Your friends are telling you about them. Maybe even some of your healthcare professional teams are selling them. I would just proceed with caution there and do it really, really thoughtfully, ideally with somebody who's trained in integrative medicine and isn't in the business of selling you something.
I'm so glad you called that out because especially now where, folks like Donna and Let's Talk Menopause are starting to create more opportunities for us to acknowledge and talk about menopause. People are realizing that, and I just see more and more products over the counter are being marketed to women. So without calling it out, it could be really confusing. If you're having those symptoms and you walk in and it says safe and effective, it's good to know that that may not be the best option for you, or walk with caution and talk to your clinician.
And just because it's natural doesn't mean it doesn't interact with your other medications. So
Oh,
particularly if you're on medications, if you've had a transplant, please, please be cautious with
mhm.
any of the natural products, whether you're taking them for menopause or anything. Jewel, can I talk about one more therapy before we go to the questions?
Well, I was hoping you'd talk about maybe two or three, like hypnosis,
Yes.
exercise, and weight loss.
Well, so let's talk about hypnosis first because this is
Okay.
super exciting. So this is not parlor trick hypnosis. This is clinical hypnotherapy. It's done with a certified hypnotherapist. What they do is they have a one-on-one session with you that's recorded, and then you go home and you do home practice. The hardest part about this is finding somebody who is certified, although we're seeing more and more people all the time because it has level 1 evidence according to the Menopause Society that it's effective in treating vasomotor symptoms. So keep this one in mind. I think we're going to see it more and more. So exercise is tricky because exercise is good for us in so many ways: cardiovascular health, mood, weight maintenance, everything, your bone strength. I mean, I could list all day, I could list benefits of exercise. Does it help with hot flashes? That's not been so easy to really tease out. For women who have a lot of hot flashes and fatigue, I really still recommend yoga. But directly for hot flashes, probably not very strong evidence for that. But again, so many other benefits. Why not?
Hmm.
And so I
Hmm.
encourage all women to exercise, of course. And then weight loss, well, this one I think is tricky. So we know that women with obesity are at higher risk for having a higher burden of symptoms. But what's your take on whether losing weight actually reduces symptoms?
Well, we actually looked at this in the non-hormone position statement, and there were two studies that demonstrated a significant reduction in hot flashes and night sweats for women that were able to lose weight. And so that's now listed as one of the recommended treatments. Um, Maybe similar to the discussion about the antidepressants, I think that it's how it lands for women is important, right? Because saying, oh, you're having hot flashes and night sweat, just lose weight, that that's not really how it should be presented, right? Because losing weight can be very challenging during menopause. But I would say if it's part of a kind kind of program that you've put together, and you have support and tools that you're successful at losing weight, then yeah, you may be able to see reductions in your hot flashes and night sweats. And just like you were saying, doing those healthy lifestyle habits are going to give you benefits in so many other areas. So there's a lot of good reason to focus on those healthy habits, and at least try to lose weight if you need to lose weight.
Yeah, I just hesitate. I mean, of course, we should encourage women to maintain their weight when it's affecting their health, but I feel
Mhm.
like that's a tricky societal issue that we
Yeah.
have really kind of just told women, you just need to lose weight, you just need to lose weight, and that's
Yeah.
not a complete message. So I like how you said that needs to be packaged. I cannot believe what time it is. We only have 5 minutes left, and there's a bunch of questions.
There is a bunch of question, and I don't know if you have one that you'd like to start with, but Christelle asked about the magnesium, and so I thought I'd just start with this one. How much elemental magnesium do you recommend per day, and which form of magnesium, glycinate, or others for insomnia? Do you take it in the morning or at night? Tell us your wealth of knowledge about magnesium, Denise.
Yeah, thanks, Christelle. I think that's a really insightful question. And I have to tell you that my opinion is too much is made out of which magnesium to take. So, magnesium is very easy for the supplement companies to manufacture. It does typically come with GI side effects, which a lot of women like. If you tend towards constipation, then taking a magnesium citrate or a magnesium oxide might just be the balance that you need to be regular. But if you tend towards loose stools, then I do recommend that people shift to the magnesium glycinate. And your typical dose is going to be 250 to 500 milligrams. And you're typically going to take that at night because many people find that it has a calming effect. If you have kidney disease, please do not start magnesium supplements on your own. Talk to your healthcare team about whether or not it's safe and what dose you should use. So 250 to 500 milligrams at night. Someone else in the questions, Jewel, asked about the spelling of the medication. And I know you already mentioned it, but I'm just going to highlight again that in the chat, you have links to the expert opinions from the Menopause Society. And even if you don't want to read the whole dense manuscript, if you just pull it up and look at the boxes, the figures, you'll see all of the medications that we have talked about and more in there.
And is that the non-hormone ones? Were they asking about the spelling of that? Yeah,
Yes.
and if you Google Menonote and non-hormone, there is a summary, a two-page summary that talks about all of those medications and kind of the risks and benefits and the dosing. So feel free to access that for your reference. Okay, we only have a couple of minutes. Let's see, what is most high yield? I see somebody asked about, is there any reason why someone would not respond to multiple different medications to reduce night sweats? This patient has tried gabapentin, Effexor, menopausal hormone therapy, and nothing worked. Any ideas, Denise, why somebody maybe wouldn't respond to treatments?
Well, I think this probably goes to how we don't fully understand why women get hot flashes. And so sometimes treating that estrogen withdrawal is enough. Sometimes we can hit it with the mechanism if we're using, say, a serotonin based therapy, but some of it is really trial and error. Also, I'm not sure that that we're always dosing correctly with
Mm,
menopausal therapies. And so
mm,
that's another tricky part to make sure that you're
mm,
working with somebody who knows how to really do the nuances of
mhm.
these treatments.
Yeah, good point. And sometimes if this person is like me, when I take a medication, I expect results like that. And sometimes these treatments can take a little bit longer to see the full benefits. So it may be a combination of all of those things: dose, duration, type. And sometimes, women may need multiple different treatments to address their symptoms too. So remembering that can be helpful too.
Do you want to do two quick ones? Because I think we just have a minute.
Yeah,
There's a question by Brandy that says, I've read that during perimenopause, women should only get progesterone and no estrogen. Is that accurate?
no.
So maybe this is the progesterone secreting IUD that Jewel mentioned. And
Yeah.
so that can be a really nice balance in perimenopause, but you're going to use the combination estrogen and progesterone in perimenopause as well.
Mhm.
And then
Mhm.
how about are transdermal forms of estradiol considered safe even for women with a history of a blood clot?
Oh, we're going to need a whole other 30 minutes to talk about this one. I would say, overall, the guidelines would say for women with a history of a blood clot, that's a contraindication to hormone therapy. There's some more nuances there depending on how you arrived at your blood clot, whether it was provoked or unprovoked, and the degree of your symptoms and the options that you've tried. So there are some scenarios where women have maybe had a provoked DVT, meaning it wasn't related to some underlying predisposition to blood clotting, but it was because of a surgery or a long trip, that are now healthy and don't have other risk factors and having severe vasomotor symptoms, that a transdermal low dose estrogen may be considered. But that's really best done with your whole care team, with probably a certified menopause practitioner, just somebody that really understands those risks and benefits well.
But I would say the takeaway for this audience as a general rule is that if you have a history of a blood clot, and particularly a blood clot that went to your lungs, you really
Mm-hmm.
should not be using
Mm-hmm.
estrogen unless you have a very, very thoughtful care team that can
Mm-hmm.
help you navigate the risk to benefit for that.
Yeah, I'd
I
agree with
think we're
that.
at time.
Wow, that went so quick.
Oh my goodness, it did. And I'm looking at all these questions. It's funny. We actually we tried to sort of limit the topic into more specifics, and this still happens, right, where we can't get to everyone's questions. But I think it also just goes to show you how sometimes complex things are and how people have all
Mm-hmm.
these different symptoms and questions. And I think the thing that I know I came away from it, and that we always talk about it, Let's Talk Menopause, is this is about getting individualized care.
Mm-hmm.
And unfortunately, not everyone can see Dr. Millstine and Dr. Kling as their providers and some of the other doctors that we have, but we encourage you to find a menopause-informed provider and to continue to ask these questions. And I think some of the other questions that we that were asked, like, do hot flashes usually resolve after post-menopause? And I think, for many women, yes, they do resolve.
Mm-hmm.
I think the other thing is for many women, they don't, or some women, they don't.
Mm-hmm.
Again, it's
Mm-hmm.
sort of like, we like to sort of, people want to know like exactly like what's going to happen to them. Is it going to stop? And we just can't tell you, right? It's sort of the unknown. And I think what is so complicated about health in general, but also about menopause, right? It's because it's a time of life where all these things can happen, and you don't know what's going to happen.
If only we could find the crystal ball that gave us all those answers. I mean, we certainly could benefit from it. But you're right, like that individualized approach with a clinician that is trained and can meet your needs is so important.
Right. And we're going to try to get to, some of those questions. We're going to start doing something called Ask the Expert, and we're going to have experts like Dr. Kling and Millstine answer some of those questions for our blog, and on social media as well. So we want to thank both of you for participating, being a panelist in our menopause talk. We really appreciate it. And we want to thank all of you for joining us. Thank you very much, Dr. Kling and Millstine. It was
Oh,
Thank
a
you.
pleasure. Thank you.